Into a red person.
Good morning, everyone. Thank you for joining us. As we typically do, we can go through and do introductions for the record. I'm Colette Peters, Director of the Department of Corrections and Chair of this work group.
Senator Jackie Winters, and I'm a participant on this work group.
Doctor?
Norwood Knight Richardson, Oregon Health and Science University.
Mr. Vice Chair?
I'm Kelly Ballas, Chief Financial Officer for the Oregon Health Authority and Interim Administrator of PEB and OEB.
Good morning, Sheriff Pat Garrett with Washington County.
Great, thanks everyone. We did hear from a couple of people. Senator Alan Bates is unable to join us this morning, as is Ms. Mary Botkin. And unfortunately, Director Fairbours Paksaresh is unable to join us today. He actually was involved in a minor bicycle accident yesterday. So no broken bones, thank goodness, but he had some follow-up he needed to do today.
I hope it wasn't on River Road.
I don't know where it was. I don't think so. I think it was in a neighborhood, he said.
Oh, okay. Yeah.
But
I say that, and just to qualify, because there's a lot of cyclists that are there, and we really don't have continuous bike path. So, lane.
So our thoughts are with him.
Yeah.
But with that, let's get started. And if other people trickle in, that will we'll just keep moving. So the first individual I will invite to the table is Mr. Steve Robbins. As a point of order, I'm just going to clarify, we do not have anyone on the phone with us, right?
You're not recording.
Because the blue guy is supposed to be on.
Why isn't the blue guy there?
Thank you, Patsy. Then we weren't recording last time either because the blue guy didn't turn on last time. Steve, since we're not live, I'll ask the question. Were we actually able to post minutes on the webpage last time? Did we actually get an audio recording?
The audio was off for the first small portion,
Okay.
and then it was the rest.
Okay, great.
New person.
See,
There. Now we're on.
now we're live. Okay, so quickly, just for the record, for our history books, Colette Peters, Director of the Department of Corrections and Chair of this work group.
Jackie Winters, State Senator, member of the work group.
Norwood Knight Richardson, Oregon Health and Science University.
Kelly Ballas, Vice Chair of the Work Group and CFO of the Oregon Health Authority and Interim Administrator of PEB and OEB.
Washington County Sheriff Pat Garrett.
Thanks, everyone. And we have with us this morning Mr. Steve Robbins, who will be the first to give us a presentation.
Great.
The floor is yours.
Good morning, Chair Peters, members of the work group. For the record, my name is Steve Robbins. I'm the Health Services Administrator for the Oregon Department of Corrections. And I'd like to start today by doing some follow-up from items in previous work groups. And specifically, I'd like to speak to the topic of electronic health records first. At the request of this work group, the Department of Corrections sent out an inquiry to all state departments of correction, Los Angeles County, and the Federal Bureau of Prisons, asking for information on their electronic health records and the status within their organizations. Of the 39 responses that we received, 25 do have a current version of electronic health records and 14 do not. Of the 14 that don't, all of them are in the same position that Oregon is, and that they're looking at acquiring electronic health records as we speak. If you look at the 25 that do, they really fall into two categories. There are those that have gone out and are working with a vendor to purchase an electronic health record and then are making modifications to that system to help it integrate with their other systems. The other group have built their own electronic health record from scratch And if we look at the comments from those states that have built their own from scratch, we're finding those are not very robust systems. They're not interacting well with their other inmate management systems. So as we looked at the list, it appears to me that we'll most likely fall into that first category where we be dealing with a vendor and then asking to make modifications as we move forward.
Madam Chair?
Please.
How many of those actually are also able to talk outside of their systems and share records, say, for instance, with the local hospitals or?
Sure. Chair Peters, Dr. Knight Richardson, all 25 that have systems, have the systems that are vendor-based, or I'm sorry, all of them that are vendor-based have the ability to go out and do that. It's the ones where they've built their own,
Right.
where they are not able to do that.
Suspect it.
Yeah. So for us, this was a good exercise. It helped us to level set where we are. It also has provided us a database of information as we progress through this process, where now we know who's using what, and we'll be able to go and ask them specific questions as we get closer to going to market and asking for an RFP.
Question, talking about outside, how many of them, and probably it's because it's relatively new, and looking at the Affordable Care Act and Medicaid, how many of them also are interfacing with some of those requirements, do you know?
Chair Peters, Senator Winters, that's a great question. I don't actually have that off the top of my head, but we can certainly get that for the group.
Because I would think, as we talk about reentry, we talk about hospital, we talk about the work with the Oregon Health Authority and all of that, that you're looking at how those systems would interface so that once we go down this road that we don't have some aha moments.
It's a great recommendation, Senator, and we just had a conversation last week at the Governor's Reentry Council. One of the outcome measures that we are working on capturing at the Department of Corrections, and one that the council also wants to hear about and have us report out on, is how many individuals leave connected to some form of care, some form of insurance, be it private or Medicaid or Medicare, and then also tracking it when they're in the community through community corrections. If this interface was there, I think that would make that easier. Right now, it's sounding close to impossible, so.
Correct.
Okay. Great, thank you.
Be great to get it at the beginning stage, of course.
That's right.
And trying to modify it as some of the people are doing that you've talked with.
Yes, absolutely.
So can we make note that the RFP would include that then?
Absolutely.
Okay, thank you.
Also, inside the topic of electronic health records, we talked about the fact that OIA was currently implementing an EHR system, and they were gracious enough to meet with us at the beginning of last month, and to really talk about their process of not only acquiring but implementing their EHR system. We met with both their EHR project manager and their contract specialist to help gain understanding as to the choice. They've chosen to go with what's called Ocean Epic as a system, and we talked to them about their methodology for procurement with the Ocean Epic system. When we talk about Ocean, that's the Oregon Community Health Information Network. And Ocean has their own iteration of the Epic system, and the Epic system is the most widely used EHR system in the country. OIA felt very strongly that the Ocean Epic system was a very good match for them, but it was also interesting in our conversations with them to find that both OIA and Ocean, who I've also had a chance to meet with directly, both had some reservations with regard to whether or not the Ocean Epic system would work for the Department of Corrections. It's a relatively inexpensive option for small and medium-sized organizations, and there's a little bit of concern about the number of locations that we have and the number of patients that we have as to whether or not it would work for us. There was also a little bit of concern voiced by OIA in that one of the big benefits for them in acquiring Ocean Epic was the ease with which they could go through the procurement process. And for the Department of Corrections, ours would be substantially bigger. And so we would actually start to trigger some of the DAS ETS requirements that would make it significantly more difficult for us to acquire it than it was for OIA. The other minor thing was that our current pharmaceutical systems use a certain barcode scanning technology, and the Ocean folks told us that they were a little concerned about how that would interact with their system. But I think in any case, every system's going to have pluses or minuses to it, and we acknowledge that. So for us, it was a fantastic opportunity to see how another state agency is currently going through the process of acquiring and implementing. We'll stay in close touch with them, and clearly, Ocean Epic will be one of the potential options for us as we go forward with an RFP.
Should we go back, Madam Chair, go back a little to the issue of pharmaceuticals and barcoding? Is it, and I know that the method of contracting and how you both systems are different. OYA is actually doing theirs different than DOC. You're part of a different pool. But is it foreseeable that, someplace down the line that even barcoding, and I'm going back to nomenclature stuff now, and I forgive me because my old brain goes back to a lot of years ago, but is it foreseeable somehow that they should be somewhat compatible in some way?
Chair Peters, Senator Winters, I will have to admit I'm not a technology expert, but I know in the conversations that we had with Ocean, it has to do with the fact that the Epic system has a module attached to it that is, there was something to do with an inpatient module that caused issues for us because we use the barcode scanning to actually track those pharmaceuticals through our process, and it is that point of transfer, getting that information from our pharmacy into the system, and then show whether or not pharmaceuticals are taken by patients and have it flow back and forth. There's some sort of disconnect there. There are those kinds of disconnects all over the place when it comes to these electronic health record systems. So it's not something that's insurmountable. It's just a challenge and something that they brought up that would be something we might have to work through.
So yours is inside the system, and somehow your system is a little different than if I was up at OHSU, which also has to have, or I'm at Salem Hospital or OYA, the tracking of pharmaceutical meds in between your 14 cities.
Correct.
That's right.
Correct.
It is a process.
Okay.
Thank you.
Okay.
Continue.
For the next few bullet points and updates for you, I'd like to invite Brian Balek out from the Department of Corrections.
Mr. Black, welcome.
Morning.
Thank you for joining us this morning.
Thank you. Chair Peters, member of the work group. I'm Brian Balek, the West Side Institutions Administrator for the Oregon Department of Corrections. In regards to the exploration of joint food contract, Department of Corrections is currently entering into an agreement with the Oregon State Hospital, which will allow us to State Hospital to purchase basic staple items directly from the Department of Corrections. It is unknown at this time the financial savings for Oregon State Hospital, but we are optimistic. In regards to the purchase of salty snacks, as part of the review of the Department of Corrections Healthy Food Grant, we focused on calorie reduction and coincidentally included sodium reduction. It has been concluded that no changes to canteen purchasing trends, and therefore no augmentation of higher caloric or sodium foods to the inmate diets have occurred. The review of purchases, along with continued monitoring of our healthy food choices, is a process that is continuously being monitored. If there are no questions, I now return the presentation back to Mr. Robbins.
Sheriff?
Thank you, Madam Chair. The second highlighted bullet, correlation between the purchase of salty snacks after sodium reduction. I'm not clear on the correlation there.
I bet I can bring some clarity to it. Mr. Balek wasn't with us for that meeting, but a member of the work group, and I believe it was Representative Williamson, wondered if there was a correlation or if there was more of a causation almost, that when we lowered our sodium in our cafeterias, that there was concern that there would be a higher purchase of sodium products from canteen.
Right.
And when we went back and looked, it didn't look like it had
No correlation.
recalibrated over here, if you will. or
Okay.
increased over here, if
Okay.
you will.
Thank you.
Okay,
Yes.
great.
No further questions?
Thank you, Mr. Black. Back to you, Mr. Robbins.
Again, for the record, Steve Robbins with Oregon Department of Corrections. Next, I'd like to share with you a slide that I've shared in previous meetings, and that's give you an update on our current Medicaid savings and our current Medicaid implementation. As you can see from this chart, the number of folks that have Medicaid qualifying events for us at the Department of Corrections is 179. This is as of last week. The number of applications that we've submitted is 144. And of those, 110 have been approved, and the remaining 34 are either pending approval or denial. We're very proud of the fact that we still have 0 denials as we've gone through this process. So it's just, we're working very well with OHA in getting this process up and running. Now, the last 2 lines, I would like to put a caveat to that. Number of claims paid and the amount paid. These are numbers that currently come from OHA. We're continuing to work through these numbers because I believe these are actually quite a bit higher than the numbers that are listed here. But I can't substantiate that with systems information and data. This is systems information and data. There's a little bit of, a number of issues we need to work through around whether or not inmates' addresses, where their address is, and so we're querying this information by address. And so we're trying to centralize that so that all inmates' address is the same for the Department of Corrections versus each of them actually having an address in their own little small city around the state and coalescing that for the purposes of reporting. Again, I can't substantiate it with data, but we're estimating at this point in time, we may be upwards of around $2 million saved at this point, not 300,000.
Wonderful.
So,
Mr. Vice Chair?
Mr. Robbins, this information will be claims paid data, I
Correct.
presume, as of June 4th.
Correct.
So what you're saying is there's a lot of claims out there that just haven't gotten into the system or through the system and gotten paid.
Absolutely. Or they have been paid, and the report that provided us this data may not have pulled all the data in for every one of our inmates.
Okay. So both of those things could happen.
Correct.
Okay.
And I would just like,
Tremendous.
I would like to pause and comment on that. It is tremendous. I think it's absolutely, the partnership that we've had with OHA has been strong, and I am quite pleased with what we've been able to accomplish
Yeah.
in a short period of time.
Yeah, it's a great
know-
example of collaboration.
It is.
Once we get, and you actually have, pretty much firm as to where we are in savings, I would like to see actually a report, if maybe we have, maybe do it before, maybe do it for Ledge Days, or maybe even before that. And that is the cooperation of is occurring as a result of, I think what was it 2087, whatever the bill was, but.
It was 2087.
My memory's
I'm
still pretty good. Because I'm very mindful that often our news is not always the stuff that's really being done, that is good news, that, so often we only hear about the things that make headlines.
That's right.
And so, talking about the collaboration and work together between, DOC and the Oregon Health Authority, I think, and a positive, and that's something that it is working, is a good thing.
Agreed. So we're happy to present to the committee either during legislative session or in the fall. One of the reasons this is so important, I would say, is twofold. One, because it's the right thing to do, and the partnership is the right thing to do. But in our budget, and remember, we're still managing to a $51 million budget hole, part of that projected savings was $13.7 million estimated savings here. So that's already worked into the budget. So we need to continue to push as hard as we can, because 300,000 is a long ways from 13.7 million, but we remain optimistic, so.
Well, but, if you take 2 million, and another 2, and another 2, hey, my little budget pen just keeps going.
Keeps going. We'll keep pushing.
Great. As a work group might remember, the Department of Corrections is dealing with Medicaid really in two areas. One is internally, as I've just discussed, using Medicaid for off-site healthcare visits. The other side of that, though, is us involving the inmates in the process for the point of release. And so what we'd like to do now is have Cindy Booth come up and speak to that topic.
Perfect. Thank you. Good morning, Ms. Booth. Welcome to the table.
Good morning. For the record, my name is Cindy Booth. I'm the Administrator for Transition and Reentry, Oregon Department of Corrections. And to my right is Sean Costriti, the Reentry Benefits Coordinator for the Oregon Department of Corrections. I've invited Sean to help in today's presentation because she is the person who is the boots on the ground individual working with individuals releasing from prison to best prepare them for Medicaid coverage prior to their release.
Welcome. Thank you.
So Chair Peters and members of the committee, for the record, again, my name is Cindy Booth, Transition and Reentry Administrator. We're here today to provide some information about reentry efforts for Medicaid and Cover Oregon as they relate to persons that are reentering the community. Beginning in late February of this year, the Department of Corrections began using Cover Oregon portal to enroll newly eligible adults in custody for Medicaid just prior to their release from prison. DOC actually repurposed an existing position to create the Reentry Benefits Coordinator position, and Ms. Costriti serves as the application assister for this purpose, and she is actually authorized to submit the online applications through the Cover Oregon portal. In addition, DOC has an interagency agreement with the Oregon Health Authority for Cover Oregon for this purpose. I'd like to have Ms. Costriti talk about both the Cover Oregon applications for Medicaid coverage and those applications for individuals that might qualify for the healthcare exchange.
Chair Peters and members of the work group, for the record, I am Sean Costriti. I'm the Reentry Benefits Coordinator for the Oregon Department of Corrections, and I'm here today to provide info about what the Department of Corrections is doing in regards to Medicaid and Cover Oregon. At this point, to be eligible for Medicaid, Cover Oregon through the Affordable Care Act, adults in custody must be under the age of 65 at release, have an income at or below 133% of the federal poverty level. So for single adults, that's approximately $14,856 a year, and also have their immigration status confirmed. The online application is submitted through the Cover Oregon portal no more than 7 days prior to the adult in custody's release. And the Medicaid eligibility decision is real time, meaning the individual is leaving prison with health insurance, and for the majority, that is the Oregon Health Plan. There is a separate process and requirement for those individuals who are 65 and over. For these, the Department of Correction must use the Department of Human Services Aging and People with Disabilities Medicaid application, which is a paper application. This process begins approximately 75 days prior to release, and DOC receives the eligibility decision 15 to 30 days prior to the release. Those individuals who may not be enrolled, it may be they have other insurance available. They may have a spouse who has insurance, such as the Oregon Health Plan, and they can be added once they're released. They become incarcerated, but they still have the Oregon Health Plan in suspend status because they're incarcerated for less than a year. They are compacting to another state upon release, so they're informed to work with their parole officer when they arrive to see about enrolling in that state's health plan. They may have had an application completed by a family member or another organization, so it's already been done, so there isn't a dual effort occurring. I am meeting with them approximately 1 week prior to their release, so they are placed on call out, which is their appointment time, and there are times that they may not show up. So I just didn't meet with them. Or they may choose to wait to apply upon release for whatever reason. I do explain the benefits to them as to why it may be best to apply while they're still incarcerated because they'll leave with insurance, but sometimes they just choose not to. And there have been 2 instances where they have just refused to sign the consent for assistance, which is basically them signing the application.
And when you meet with these individuals, are you meeting with them via video?
Chair Peters, no, I am not. I am meeting with every individual in person. So I am traveling to all 14 institutions in the state. Here in the Valley, from Portland to Salem, I'm going to those institutions approximately 1 time a week. And then I do make a trip to the east side once a month to meet with the following month releases. So I just was in Ontario and met with all of the June releases. And then I'll travel to Umatilla this afternoon to meet with all the June releases at Two Rivers.
Well, I have to say, with approximately 400 releases every month, I am very impressed, and I appreciate you taking the time this morning to spend with us.
Thank you.
May I?
Yeah, Mr. Vice Chair.
Couple of questions. Could you spell your name for me?
Yeah, Chair Peters and Mr. Ballas. It is SHAWN, and then my last name is COST hyphen STREETY.
STREETY. And then my other question is, is there any work being done now on some sort of a warm handoff upon the day of release, or some effort to kind of make sure that people get an opportunity to get an appointment with a physician or whatever services they need, addictions and mental health services, soon after release as possible?
Chair Peters and Mr. Ballas, at this point, what is happening is when I do the enrollment, I print off the qualification summary screen showing that they have been enrolled into the Oregon Health Plan, and it is noted in the chronos for the parole officer, so they are aware that they have been enrolled and it's active. But in regards to setting appointments, I'm not involved in that piece, so I'm not sure what is occurring after release, but all of the community corrections agencies through Ms. Booth and myself attending the OACCD meetings, they are aware that this is being done within the institution, so these individuals are leaving with.
Is it common that they meet with their parole officer the first day after the first day they're released?
Chair Peters and Mr. Ballas, again, Cindy Booth for the record, and correct.
It
They
is,
are
okay.
required to report for supervision within 24 hours of release from incarceration or upon a time period that's set if they're unable to meet in that time period due to travel, say for. If I may, I can provide a little more information about those individuals who have extraordinary health issues at release. The Reentry Services works closely with the Health Services section of the Oregon Department of Corrections to have releasing nurse managers actually case manage those situations so that individuals not only have the appropriate care and handoff, that continuity from institution to community corrections setting, but they're also arranging housing, transportation for most individuals, things like that. That is for individuals with a high level of mental health as well as physical health needs.
Great, thank you.
Thank you.
Sean Costriti for the record again. So for the Cover Oregon portal, again, that is being used for the 64 and under releasing population. I'm producing a list of adults in custody who are releasing once a week, so I can attempt to capture everyone. I'm scheduling the call-outs through the release counselors or a designated individual at the institutions. I'm not scheduling those individuals who have an open detainer that will result in further incarceration. So those who are going to immigrations, the United States Marshals, or have other state and county detainers. I'm, again, meeting with them about 1 week prior to their release, and they have the real-time eligibility decision. For those individuals who are 65 and over, again, as I stated before, I'm meeting with them approximately 75 days prior to release to complete the Medicaid application that's provided by the Aging and Disabilities through DHS. And in those cases, they cannot have assets over $2,000. They have to, if they're not born inside of Oregon, we have to have their birth certificate so we can prove their citizenship. And there's an application packet that's mailed at 45 to 60 days. That includes a copy of their birth certificate, either their Social Security card or Social Security card application, their photo ID, their inmate trust account, just to show that they don't have the $2,000 in assets. And if they do have a checking account or savings account or a car, we have to mail in a copy of their title, copy of their checking account or savings statement, just so we can prove that they don't have $2,000 in assets. So that's a little tricky, especially in the birth certificate department, trying to make sure that all of these individuals have birth certificates
That's
if they're
tricky in
born
of
out.
itself.
Just the process, finding out if they have a copy of their birth certificate in their file, and then going about ordering it, and sometimes they don't know the information, such as their mother's maiden name. And working with the institution to make sure that birth certificate is getting ordered. So we have it, and we're not waiting until they're 60 days to release to try and order that.
Cindy, question, how many, are all counties, all 36 counties and community corrections on board in reaching in early and making the transition work for reentry?
Chair Peters and Senator Winters, it is true that all counties do participate in the conversations. To the best of their ability, they provide at least a phone reach-in. Some do video reach-in. A lot do in-person reach-ins as well. To say that all 36 for every single individual, I cannot say that's true.
Could we, in going forward, because we're, part of the other responsibility I have is with 3194, we actually took the 4 co-chairs and gave us each an issue to work on, and mine is the specialty courts. And one of the things that came into having the discussion around specialty courts is the whole issue of resource availability or not. And so we're talking about doing a mapping. It would be very helpful because not all counties have the ability to have, the reach-in and to be working with DOC for this whole smooth transition out. So, keep that for me on your radar screen as we talk about this whole mapping and what really does exist in Oregon with respect to, we're very good at doing policy in this building, but the other part of it, we're not so very good when it starts talking about the difference between Multnomah County, Marion County, Washington County, and Malheur or Ontario. And so at some point, I think that we need to begin, as we start talking about implementing some of these wonderful kinds of concepts that we have, that we also identify where the ability to do what we're asking can get done. So
Thank you, Senator. We will. And the sheriff might be able to speak to the efforts on the ground more specifically. We are trying to hold ourselves accountable to those policy decisions. As you know, we're mapping the Department of Corrections. We're establishing targets and measuring outcomes. This is one of those outcomes that we will be measuring out of our Community Corrections Division. The data collection is our struggle right now, but we're trying to work through that. Sheriff, anything you want to add?
No,
on
I think you
regions?
captured it beautifully.
Okay, great. Thank you.
Sean Costridi again. Just to finish with the 65 and over population, again, we receive a decision from DHS about 15 to 30 days prior to the individual's release in regards to whether they're approved or denied. If I can say those that I've mailed in, no one's been denied because they've been under the asset level. If an individual who is 65 and over is over the $2,000 asset range, then they can go through the Cover Oregon portal, and I will meet with them about a week prior to their release. But typically those individuals have other insurance available on the outside, whether it's through the VA or their retirement. So rarely, if they're over 65, are they going through the Cover Oregon portal.
What percentage of them do have private insurance or do have VA coverage?
I don't have the exact, Chair Peters and Senator Winters, I do not have the exact number of percentage. It is a very small handful of individuals that I do meet with that have other insurance, whether it's through the VA or, I have met someone who through PERS has insurance. I don't have an exact figure, but it is very small. And 1 week to the adult in custody's release, I'll be contacted by DHS to verify their release location and their release date. So on the day of release, their medical card will be opened in the DHS office closest to their release.
Great.
So, and now turn it back over to Ms. Booth.
Thank you. Appreciate your presentation.
Thank you.
So members, the Affordable Care Act is a grand expansion for corrections agencies around the country, as nationally more than 730,000 federal and state prisoners release each year, and it's anticipated that well over half of those individuals will be eligible for the Affordable Care Act as it's implemented in the various states. In Oregon, we're particularly interested in the range of provisions that are relevant to persons with a criminal justice system involvement. The healthcare exchange establishes an individual's eligibility for subsidies and tax credits. And as Ms. Costriti talked about, the majority of individuals releasing from Oregon prisons are actually eligible for Cover Oregon because they're under the income limits. Dependent coverage is another part of the healthcare expansion. Coverage for children is available up to age 26. More importantly, coverage is guaranteed for pre-existing conditions, and that's a significant concern for our population, as we spoke about a few minutes ago, because they're often chronically health challenged. For those individuals on community supervision, on probation, post-prison supervision, or parole, many of the county community corrections agencies have already established or engaged with partner organizations to have processes in place to ensure that these individuals are also covered under the Affordable Care Act.
Ms. Booth, can we go back a point? So you say that the issue of guaranteed coverage for pre-existing conditions is a concern for us?
No.
Can you talk through that?
Chair Peters, I intended to say that it is one of the concerns that the healthcare addresses, the Healthcare Act
Great.
addresses.
It's a relief for us.
Yes, a
Yes,
grand
got it.
relief for
Thank
us.
you.
Yes. Yes. And then for individuals that are releasing from DOC's prison, we actually provide documentation as to their eligibility, both by the documentation that comes from the Cover Oregon portal or the Medicaid eligibility status, and by noting it in Chronos. Again, as talked about a few minutes ago, actually tracking information new like this in our computer system is challenging. So we use the information segments that are available and that POs are most accustomed to having access to 24/7, and that is a case management system that relies on Chronos.
And just for the work group's benefit, our system is so antiquated. We really are working with a green screen. It is COBOL-based. And so this is a system that has been in dire need of replacement for a couple of decades. So, thank you.
And as Sean Costriti mentioned a few minutes earlier, we do regularly meet with the Oregon Association of Community Corrections Directors to talk about the department's implementation of the Affordable Care Act, as well as the Medicaid applications for those who are age 65 and older, to keep them apprised of the department's efforts and to also hear what each of their counties are doing with regard to the Affordable Care Act expansion. I'd be happy to answer any questions you may have.
I just have one, and I think it's probably the Oregon Health Authority, and that's on the issue of portal if we change to the new system and what that would mean for DOC.
I don't have an answer to that.
We'll just table that until next meeting.
Great. So we'll make note and have somebody answer the question for the next meeting. Thank you, Matt.
Thank you, and we'll turn the presentation over to Director Peters.
Great, thank you.
Thank you.
Okay, so during the last work group meeting, we covered 6 of the 12 recommendations and next steps, just to give you a refresher. Those recommendations and next steps were electronic health records, which you received an update again on that today. Legislative remedies for House Bill 2087 to enable suspension versus termination of Medicaid eligibility. And we have an LC placeholder for that issue. We talked about creating a case management program with health classifications and clinical guidelines, and the agency is moving in that direction. Prison to community connection for all aspects of healthcare. That's really an integrated conversation that ties to the Medicaid expansion conversation, no doubt, as we talked about this morning. Nutritional review of food and associated cost. We're still looking to the committee for recommendations in that regard, and we'll talk about that later as we continue to meet, and explore providing healthier food options through commissary and associated impacts to healthcare, as well as balancing that with the safety and security of our prisons when we have that conversation. During this work group meeting, we plan on covering the next 3, which you'll see up on the board over here, or on the screen over here. One of the recommendations of the work group was early mental health intervention to prevent incarceration. Thanks for helping me out, Steve. Through the passage of 3194, a public safety policy package enacted through the 2013 session, as you are all aware, the task force on public safety was established. In order to oversee various implementation pieces of 3194, the task force has developed a subgroup model. The senator mentioned that to some degree a moment ago. And subcommittees have been created. The subcommittees are chaired by task force members who will hold regular meetings and report back to the entire task force on progress and implementation. I'm happy to share that one of the subcommittees will focus on specialty courts, as the senator mentioned, including reentry, drug, veterans, and mental health courts. The chair of this specialty court subcommittee happens to be our very own Senator Jackie Winters. So as a work group, I think that we need to decide, is this something that we want to study separately or defer to the subcommittee of 3194 to engage in that conversation? And I offer that up to the work group members.
I actually think that it belongs with the discussion in the subcommittee group on specialty courts, because we held our first meeting to get our bearings, and we'll begin to start talking about areas that we need to actually focus on. So this could be one of those areas that we need to focus on, as along with all the other specialty courts. As you know, we'll be getting off into actually talking about best practices and evidence base, and I think that's kind of our first step, not so much program, but actually talking about what is and what is that we can actually look to later and say, yes, it succeeded, or no, it did not.
So really looking at the evaluation piece.
Evaluation piece. There's, I'm sure there's a lot of models out there. And, here again, what model may have worked someplace else. And that's what brought up the mapping question in my mind. Because if you start talking about, well, you need these various components in order to make a drug court work, Ontario may not have those same components. So what is evidence? What is the standards? So I think that's where we're going to start. Okay. That does not mean that the intervention to prevent incarceration doesn't belong somewhere in that spectrum.
Fair enough.
Senator Winters, is the idea that there will be a pilot or multiple pilots?
We haven't got that far yet. We're still trying to struggle to get, we have until actually not this legislative session, but the task force will continue on until 2017.
Oh, okay.
because it's recognized, the four components are components that lends itself to longitudinal study and involvement rather than a quick fix. Because
That's great.
yeah, it's not something, I think, that if you look at 3194, and the intent of 3194, we knew that we will not be able to implement all those components, nor have the statutory pieces all in place within a short period of time.
Agreed. Any other comments from the committee? Sheriff?
Thank you, Chair Peters. I would concur with the senator in keeping that discussion in your committee for a couple of reasons. One, each one of the courts that you mentioned, I think you mentioned, four, those have very protracted, complicated dynamics that each of the courts attempt to address. And boy, that can get to be a long discussion and a lot of data for each one of those courts. Two, they are staff intensive. And we have a wonderful drug court, and I think that represents a hierarchy of need in our county. Drug court's one, mental health court would be number two. And we just stitched together some resources to kind of have a standing mental health court, but the capacity is very, very limited. So they're so valuable, but it's a very lengthy and complicated discussion. I'm glad to hear you're willing to tackle that.
I think I drew I don't know
straw.
how I drew the straw. But also, it's like, drug court, and whether you have both drug court and mental health courts combined. I mean, there is the conversation that, you have the co-occurrence, and perhaps, you're, in some arenas, you may want to tackle that, or your court may be structured to handle both. And I was thinking, and I could be mistaken, that I believe it was King County that they did combine the two. That was several years ago. And so, but it's still a lot of work yet for our little subgroup to tackle. And I think our first is to talk about the standards and the assessment piece of just actually what we're looking.
Fantastic.
And then the mapping is underway. And as much input as we can get into the mapping, I think, will be extremely helpful. Because as I said, when you start talking about best practices and you start talking about longitudinal assessments and outcomes, everything doesn't fit within those widgets and those squares. And so, in my mind, when we're saying whether something works or not, Wheeler County, and just by mere population and what's there, is totally different than what's in Multnomah or some of the other, or Polk. And I think I started thinking more and more about this as we look at what's happening in Southern Oregon and the absence of passing levies and what have you, and even those kind of resources impact the work that we're talking about here. So I suggested the mapping, and so we're going to undertake that particular
Fair enough.
challenge.
Doctor, any objection to deferring this to the work of the subcommittee?
Not at all, I concur.
Okay, great. And for those members that aren't here, I will note that the subcommittee does allow for public comment. And so
It does.
any member of our work group that wants to participate in that conversation.
I will also suggest any member that's on this panel who want to become a part, and we'll make certain that you get the notifications and everything, can come and participate, because we were actually at our last meeting, talked about others besides the formal members of the group. So
That would be good.
Perfect. So those members that are interested, please connect with Mr. Shoemaker by email, and he'll make sure that connect happens.
Can we indicate that now?
Yes.
That would be efficient. I'm interested.
Anyone else? Okay. Can we also include that in the next email that we send out to the whole panel, so that those members that aren't here today understand that we've made this decision, and if they are wanting to participate, that we'll connect them to that group. Great, thank you.
I'd like to make a comment, Senator Winters. Dr. David Labby, who is the medical director of Health Share of Oregon, visited San Antonio, to get some understanding of their drug courts there, and I'm wondering if if you would be interested in having them at least come to a committee meeting.
Certainly, because we will start holding, the same kind of informational hearings and what have you, yeah,
Okay, I'll check in with him then.
okay.
Thank you. Okay, now, Mr. Robbins, back to the table. Thank you.
Chair Peters, members of the work group, again for the record, my name is Steve Robbins, Health Service Administrator for the Oregon Department of Corrections. Next, I'd like to speak to the recommendation that legislation be proposed to prohibit insurance companies from terminating insurance coverage while their customers are incarcerated. The Oregon Department of Corrections has closely examined the concept of prohibiting insurance companies from terminating insurance coverage while incarcerated in the state prison system for the potential of a legislative concept in the 2015 legislative session. This concept arose out of the passage of House Bill 4110 during the 2014 interim session. In its final form, that bill limited this prohibition of termination of insurance to those in pretrial custody in the counties. Because DOC typically isn't dealing with a significant pretrial population, we've been investigating the impact of this concept on our entire population in the state system. At first blush, this appears to be an innovative option to decrease costs by requiring these insurance companies to continue covering their customers while they're incarcerated. As we look at operationalizing such a concept, however, the issue becomes much more complex, and we're finding that many of those issues may outweigh the benefits. As a first step,
Doctor?
Yes, thank you, Madam Chair. You said many of these issues, and could you give me an example?
absolutely.
Please? Or are you about
Chair
to do
Peters.
Yeah,
that?
he's going to walk you through
I'd
it.
like
Sort
to
of
do that.
uncovered.
Absolutely. As a first step in our analysis, we contacted, through the help of Sheriff Garrett, we contacted Washington County, Marion County, Multnomah County, so that we could get their thoughts on how they plan to operationalize the passage of House Bill 4110, so that we as a DOC could understand how we would operationalize it if similar legislation were passed. At this point, however, the counties are still grappling with how to implement that process, and so they've asked us to come back to them later in the year, because this actually becomes effective as of the first of the year. So they've asked us to come back in the fourth quarter and circle back with them and ask how that's going with them. Obviously, the purpose of such a legislative concept is to reduce the cost to the state for inmate medical care. The analysis, as we're beginning to look at this, show that that might not be the case. One of the things to remember is that the Department of Corrections, we currently pay medical bills. We don't actually bill for services at all. So to bill insurance companies for our services would require an entire additional either staff or some sort of vendor contract for us to accommodate that medical billing component that doesn't currently exist. If you remember, in our system, we have not only internal to our system care, where all of our employees are providing health care, but also the off-site care component. If you look at the on-site care component, one of the real issues we have, as we talked earlier, we don't have an electronic health record. And for us, we don't actually code internal medical interactions at all, which is necessary for billing. And in other words, we don't really have an internal method for applying a billable event to the care we provide inside the system. Now, that's something that could happen, but also as we look at an electronic health record, all the options we've looked at so far and discussions we've had would not to include a billing component to an EHR. So if this were to happen, that would add that extra component, would increase cost for us there in just the acquisition of the EHR system itself.
Do we know to what degree the cost would be increased?
No, Chair Peters, no, we do not at this point.
Madam Chair?
Please.
Do we know, if you ran the numbers, what the earn out of that expense might be down the line? I suspect that if you grow and mature your system, somewhere down the line, it in fact might pay for itself. no other reason, it builds in a certain amount of efficiency. The other part is there an ability to contract the coding and billing process outside of the system?
Chair Peters, Dr. Knight Richardson, the answer to your second question is absolutely yes. It's possible to contract that out. As far as the first component, we're actually embarking on a full-blown cost study. We're hoping to have that done even within the next 5 or 6 days for the sake of preparing a fiscal impact statement for any potential legislation. So that is one of the elements that we are definitely looking at is really this fixed cost component and an initial spend and what that would cover as we move out.
Because I would urge that it may be a mistake looking back a decade from now, back on the decision not to start coding and really sort of that's the standard nowadays. It also helps as in the transfer of notes, as that coding correlates diagnostically, and someone seeing that with the new ICD-10 or the DSM can more precisely determine what the level of or the diagnosis and the level of care that's necessary. So,
Well, you'll be able to get some clarity and better data once the county actually on the bill that was passed, because that will give us at least some idea of how many of those in pretrial actually have private coverage, which we do not know currently. And my suspicion is that there's not, it's a very small pool. And I suspect that probably we may have some of them that have the Oregon Health Plan and some of that, but I think getting that data from the counties begin to look at really what is and what exists, because when we passed the legislation, those numbers were not there. We don't even know what the universe is. So if you go from pretrial then into the next phase would then be whether or not they're getting into DLC.
Chair Peters, Senator Winters, I agree. That's definitely something we are considering. When you think in terms of the percentage of folks coming into the system, the public safety system with private insurance, it's a very small component. By the time, but they're going into the county. By the time they run through the county system and get to us, that is a much even smaller component of folks that would still have any kind of coverage when they get to us. And that's what we're starting to see bear out as we do this analysis is there's a fixed cost component to this building machinery to handle this process, and the cost of that machinery is starting to look like it may outweigh the benefit from the small number of folks that by the time they get to the state system. But it's not something we want to discount out of hand. We want to talk through it and make sure that we do the analysis. If you look at the off-site medical care component for us, as we've talked about here, we're currently starting this process of using Medicaid to offset our costs. And the interesting thing is if you look at the privatization discussion alongside with a Medicaid discussion, it looks as though the privatization discussion may not really save the state any money because what's happening is we would then be having to make a prioritization decision between whether or not private insurance was billed for that offsite visit or Medicaid. And if it's Medicaid that's billed, remember when Medicaid bills, that's all that gets paid is the Medicaid rate. With insurance, there's a component like all of us when we go to the doctor, there's the insurance component that's paid by insurance, and then there's the part that we have to pay up to a deductible. The Department of Corrections would be on the hook for that component. So actually this transition from Medicaid to privatization may actually have a cost component to it rather than a cost savings component. So that's one of the other elements that we're looking at there. If you look at inside our system, we currently have no means for tracking each individual inmate's insurance plan, whether or not their families have continued to pay the premiums, whether or not their deductibles have been satisfied and what those deductible levels are, the different pharmaceutical formularies that are involved with each of the various different plans. So as this group has heard many times over the past few months, we're required to provide medically necessary care to a community
Regardless.
standard, regardless. So that just means that to determine whether something's privately covered, Medicaid covered, third-party administrator covered, or internally covered, all of that work requires some machinery that we currently don't have, and there's a cost associated with that. So that's what we're putting together, is what we feel that cost component will be.
So if I have a spouse that's incarcerated and I have have coverage, and then that spouse goes to your facility 9 times out of 10, and probably 10%, 100% of the time, I'm dropping the coverage. I'm not paying the premium.
Senator Winters, we agree with that assessment.
Human
But
nature tells me that that's what's
what's
going to
gonna
happen.
I do want to be clear, though, that we owe our policy group at DOC, as well as this work group, more than just a list of challenges. We want to put some dollars to these so that we can actually look at the specific fiscal impact. The financial variables to this are endless, so we're just going to have to pick a set of assumptions and run with that set of assumptions and provide the fiscal analysis. In the meantime, we do have a legislative concept placeholder for this in the event that we want to move forward with it. Any questions?
Very good.
Okay, thank you. And next, to cover legislatively mandated exercise programs, is Mr. Valek.
Thank you, Mr. Robbins. Mr. Black, welcome back.
Thank you. Chair Peters and members of the work group. Again, for the record, I'm Brian Belek, the Westside Institutions Administrator for the Department of Corrections. I will now talk about legislatively mandated exercise programs. We are in the process of surveying other states to determine which states, if any, have mandated exercise programs. We look forward to sharing those results with you at our next meeting. In the meantime, here are some of the exercise opportunities we do offer within the department. All institutions make available exercise equipment. Many institutions offer various programs such as yoga, video exercises, running tracks, seasonal leagues for volleyball, basketball, soccer, flag football, pickleball, and horseshoes. DOC previously ran an alternative incarceration program, AIP, known as Success Using Motivation, Morale, Intensity, and Treatment, otherwise known as SUMMIT. The program was a boot camp model for men and women at Shutter Creek Correctional Institution in North Bend that started in 1994. In 2003, the Oregon legislature approved an expansion of AIP focused on inmates with moderate to severe substance abuse problems, drive-in offenses. The treatment program served a high proportion of inmates incarcerated for drug offenses, drive-in offenses, theft, and burglary. The primary components of the program were cognitive change, education, substance abuse education, physical work and exercise, decision-making, anger management, spiritual wellness, and teamwork. The physical work and exercise portion of the program consisted of a boot camp style model. National research later indicated that the boot camp style model was proven to be ineffective. A few of the challenges that the department faced with the exercise portion of the program included some inmates were not medically cleared to participate in the exercise component of the boot camp style program, making them ineligible, resulting in unequal opportunities to participate in other program components that they would have needed and would have qualified for. Given many of our staff were not certified fitness instructors, nor was a mandatory part of their qualification for their position, to have staff instructing in fitness presented a liability risk for the department as well. And if you don't have any further questions, I'll turn it over to Chair Peters.
I have a, Madam Chair,
Please.
just a question, and I don't know if anybody has done any research on this, but what's the average weight, if I looked at weight of those in the institution, and based on, the 14 institutions, and then in comparison is, what's the average weight of personnel?
So, Mr. Black, you want me to take this one?
Absolutely.
All right. So, Unfortunately, because we don't have an electronic health record system, we cannot tell you what the average weight is of the adults in our custody. I know that while I was at the Oregon Youth Authority, we began measuring that. We began measuring mass body index on the way in and on the way out to see if we had a healthier human being leaving than coming to us. It's certainly part of our vision. That is where we want to go. I can tell you anecdotally that it is not a healthy population. They come to us not having preventative care, not having engaged in a healthy lifestyle. They are actually 10 years older biologically than they are chronologically. And I can tell you just anecdotally, even as I walk death row, one of the things that was very obvious to me is that the majority of them were overweight. As I talked to them individually, many of them shared that they had been diagnosed with type 2 diabetes, which they didn't have when they came to us. So we recognize it is an issue, but the actual data points aren't there yet. As it relates to staff, unfortunately, I do have the data, and it is not good. We just had OHSU come in and do a random selection of about 100 officers in the Valley and did a medical assessment. And they learned that while the nation is faced with a 73% obesity rate, at the Oregon Department of Corrections, we're looking at a 90% obesity rate.
I raise that because, it just kind of goes lead by example. And, I sat here and I was thinking about 5210 and some of the things we've done in this community to try to get this community engaged itself. Mandates normally, typically in my world and others don't work. The human behavior is that we don't like to do anything somebody tells us to do. But we're competitive by nature and we like contests. We do like to make certain that we're competing against each other. And I thought of that as I sat here and said, gee, I wonder if somebody could talk about, doing something in a competitive way between the staff and the residents.
So we'll have more to report on that. So the executive team at the Department of Corrections has said that the wellness of our staff is our #1 strategic initiative this year. Deputy Director Mitch Morrow is going to lead the efforts in that regard. He is not just the deputy, he's also a PEB board member, so he's engaging with
You
PEB
might
on
want
this
to, I remember
conversation.
when we used to have, it was a lot of years ago, and sometimes my little chronologically memory reach back and get some things, but you remember in this building we had, in fact, it was Senator Day, LB Day, and the newspaper reporter Blankenbaker. They decided to be competitive on weight loss, and this became quite a bet around this building, and the money went to for Christmas gifts for needy children, and I had the task when I was the ombudsman of picking the person on the first one. So it's things like that got this building going, and I think that we can think of ways of what have, not just your staff, but I thought about, the good job you guys did on that memorial and the veterans.
Wasn't that incredible?
That was absolutely incredible. If anybody had said from outside, well, they can't do it, and they proved that they could do it. Mm-hmm. So that's just some thought.
No, and that's the conversation that we hope to have now. So one of the recommendations that the work group wanted further conversation and study on was a legislatively mandated exercise program. And so that's what we need to talk about. Is that something we want to engage in, or do we have other recommendations that we would like to move forward? Doctor?
Madam Chair, there is a correlation, of weight gain and certainly poor diet, lack of exercise, but hidden in there is also stress and anxiety. And that's for both the
right.
guards and the population. So I would advise that as we do this, we also include those components. That I have many patients who are not incarcerated or prison guards, but stress, and I have to get the stress before the the weight loss actually takes.
That's
because, so I would recommend that somewhere in this programming, we realize that it is a reaction sometimes to internal turmoil.
Thank you for that. The wellness initiative that we have for our staff right now is in two components. There's the actual physical well-being, and then it's the mental health of our staff. PSU came in, and again, the statistics are as equally depressing as they are the physical health because they're interconnected. But we were noted to have higher levels of PTSD
Yes.
than police officers, firefighters, and even those in active military duty, which means more anxiety, more stress, more drinking, more divorcing,
Absolutely.
dying young. We had, in that medical study, confirmed that over 90% had hypertension or prehypertension, and medically indicated stress markers that were incredibly high. So they are interconnected, there is no doubt. So the other side that we're working on is that mental health component and trying to train our staff how to get from that state of hypervigilance
Yes.
down
Yep.
to vigilance.
That's right.
Because the stress markers drop dramatically, and you're actually more effective in your job. You can see more clearly, et cetera. We are talking about how that modeling, if you will, of healthy behavior could impact the adults in custody as well.
Because you have an institution that models after each other. I mean,
That's
let's
right.
be on both sides. I can remember the study that was done a lot of years ago where they reversed roles, and it wasn't too long after each was taking on the characteristics of the other. I think it was done at either Stanford or can't remember where it was done. But so, I mean, that's the world that you live in out, whether it's OSP or Coffee Creek or whatever, and it is a modeling stressful environment.
Well, the fact is that the prison guards are in prison as well.
Right.
Right.
So,
Right.
it's.
And we ask a lot of our correctional officers. They are asked to engage, they're asked to role model, to treat these individuals with respect, and really walk up to that professional line in terms of engaging with them and focusing on the affirmation piece in a prison environment. So it's what we ask of them is stressful in and of itself.
I don't think we've solved this one today.
We haven't. Any recommendations that the work group would like to consider? So,
I'd like to hear what other states are doing, yet we still have, and I don't know what is going on in the rest of the 49, of how they are actually coping and addressing this particular issue, both from the standpoint, the standpoint of the residents as well as staff, because I actually think that when you start looking at the institution itself, it is it's both.
agreed. And Ms. Garcia is reminding me, we have health incentives now for staff, right? PEB has pushed those forward for us, and so we're hoping to connect with those as well. And I will tell you, as the woman at the helm of the prison system in Oregon, I do get nervous when we talk about legislatively mandated programs such as this. For two reasons. One, I think it can impact the safety and security of our prisons. When you give our inmate population something to unite on, they will. And so I would recommend caution from that perspective. But the research also tells us you can't mandate health. A doctor, as you mentioned, you needed to get to the stress and anxiety of that individual and help them mentally improve before they could even physically improve. The doctor from OHSU, who is going to help us create a wellness plan for our staff, said very clearly, I can create the best wellness plan on the face of the earth and have it specific for correctional officers and their lifestyle. But until that person who sits in front of us wants to make change, it won't occur. And so for me, we do have a captive audience. And so as you reflect on recommendations, and we'll defer this conversation to next time once we hear from states, I'd like you all to be thinking about an education component, both from a nutritional perspective and an exercise perspective, because we've also talked before how we can provide 3 healthy meals a day, and all of that can be wiped away with a couple of bags of ramen noodles, right?
Well, I would agree with mandates, and that's why when I worked with this community, and we came up with 5210. Very simple, very straightforward. And then we said, and that was started out of Maine, by the way, it was something, but we adapted it to us. We developed a part of that, a tracking program so that individuals could go and see what they're doing. We then made it competitive. We then decided, in fact, by the way, there's no state dollars in this at all. It's all community driven. We now have developed a process where we've got an app so that the individual can actually download and go on. And it started with the same questions that we're talking about here. A community that is not practicing wellness. Obesity and diabetes is in Marion County is one of the largest in the state. So how do we get a community engaged to address its own issues? And so the simplicity of it is 5 fruits and vegetables, 2 hours of TV, 1 hour of exercise, and 0 sugar. And it's easy to remember. And so anyway, that's what we're doing here. And I think whatever you do, it has to be for, both staff and individuals. It has to be straightforward, and it has to be a part of a wellness plan that individuals can do. And then the competitive side of it was, hey, I can track it in my family, I can track it with my peers, I can track it with kids in school, and
There you go. Okay, so then what I'll recommend is while we're studying what the other 49 states are doing, we can, as correction professionals, look at that and actually come up with some proposed recommendations for the work group to consider that would balance health improvement with the safety and security of our prisons. Fair enough?
And I think that safety that you mentioned is critical.
It is, because it's interconnected with the stress, right? So it's stressful already. If our prisons become less safe, the stress of those incarcerated goes up, the stress of those who are actually our corrections professionals
Pam's
go
gonna
up.
come get me pretty soon, so I guess
We're doing pretty well.
good. Okay.
Any other comments or questions? All right, we'll revisit this topic next time. Mr. Black, thanks so
welcome.
much for your presentation.
Thank you.
Okay, so recommendations and next steps for future meetings. I believe, I'm going to look to Mr. Shoemaker. I believe that these last 3 recommendations are our final 3. Is that correct? Okay, so just so that you understand and have context around where we are and where we're headed, the work group decided that we would complete our work and recommendations by our October meeting so that the department had an opportunity to prepare a report for you to review and submit to the legislature at the beginning of the year. So we have now worked our way through all but 3 of the original recommendations. So next we'll be looking at ongoing analysis for possible early parole release restructure by this work group, health incentive programs for adults in custody. Somehow, Mr. Shoemaker, you already knew that we were going to have that conversation again, so nice job. Track and measure healthcare coverage upon release, which we touched on in part today. And so we will be prepared to present information on those 3 areas. Is there anything else that the work group is wanting to hear about before beginning to develop our final recommendations? Good? All right. So with that, we will see you back here on July 28th to continue this conversation. And I believe, well done, you finished 30 minutes in advance, so there's the gift of time. Thank you for your participation.
Oh, thank you.
Thank you.
We just ran a very excellent meeting, keeping us on task.
Thank you, ma'am.
Very well.
Madam Chair.
I'm going to hire you.
Really? Good. If I lose my day job, I've
You can always come.
got a backup.